Welcome, welcome, welcome back to Rad Talk, where medicine and collide. I'm Dennis,
And I'm Gage.
and we're going to be talking about a lot of new things. There's a lot of new graduates out there, medical graduates, sonographers, radiologists, and we just kind of want to go over some different tips and things like that. Um, Being new at something, sometimes you get nervous about taking, in the sonography world specifically, you get nervous about taking images. Am I taking too many images? Am I not taking enough images? Some protocols will kind of guide you image to image. But being a new sonographer, sometimes you see something and maybe you're unsure of it, and you take an image of it, and then you measure something, and then it goes to
Hmm.
the rad, and the rad's forced to say something about this measurement or ask you why you
Yeah,
took this
yeah,
measurement.
yeah.
And something that can be completely normal, whether it's like being a new sonographer, maybe you take a picture of a renal pyramid or something
Hmm.
that you say is a cyst, but it's just a renal pyramid, so it's just a normal thing. But you're nervous and you don't want to miss something,
Hmm.
and so now the
Yeah,
radiologist has to, I don't know if you go in and delete those images and say like, hey, this is a renal pyramid, this is, but some PAC systems, it's to delete images, it's like an act of God. It feels
yeah.
like.
I've never deleted an image in my life. I didn't know that was a possibility.
Yeah, is
Like
and
once you sent it, I thought that was it. Like that was final. So
what's interesting is, so some hospital systems allow the sonographers to go in and delete images, um, after they've sent them to the radiologist, before you've sent them to the radiologist. And so I think that's a great way to have another sonographer look over your images maybe before you send them to the rad, especially if you're a new graduate. I know as a new graduate, I would bring a lot of, not a lot, but like people in the room sometimes. If I was like, is this a pyramid or is this a cyst or is this
hmm.
like um, just being so nervous that you're going to miss something, that you're over checking things. I think that's a
Hmm.
like I think that's, looking back, I think that's a good quality, because it really shows that like I really care, and I'm taking the time, like I'm trying to treat my patients like a member of my family. Like I would want, like, if I'm, everybody starts out new, and so everybody is new at something at one point. And so I think to be understanding to like, hey, I'm going to bring you in and take a look at this. I mean, sometimes now I even bring folks in and take a look at it. And there's nothing wrong with that, to get a second opinion. But think being new, you do it more. Well, I hope you would maybe do it more, just to
Yeah.
be more caring, and not as, you don't want to be cocky and be like, I'm new, but this is, I know everything.
Hmm.
And so and hopefully that the other sonographers are also understanding, or whatever modality you're in, are understanding that this person's new. We need to take our time. If they have questions, like, that's okay. Because I've
Yeah.
also worked with people that were like towards retirement, and they were like, I don't do new grads, I don't
Yeah.
do
That's fair.
students,
Yeah.
I don't
Yeah.
want, I want, I got my 2 years left, and I'm retired. I'm done. I don't want anything to do with you guys. And I worked with an individual who was that. What was very interesting though is I was able to develop a friendship with them somehow. I think maybe, maybe because I was young or old, and they looked at me as, a son type figure to
Yeah.
them, and
Yeah.
so they were like, okay, I'll go out of their way and help him out. And so um, I think that can be very, very difficult.
I
Taking
think
images. Yeah, go ahead.
one thing that maybe helps kind of, I guess, explain how it works when you're in ultrasound school, like how, because you obviously you have to scan and everything, but
Mhm.
how does that whole process work? You go in and scan, is somebody there, back scan? Yeah, so explain kind of
Yeah,
how it works in ultrasound school, and then how that's different from how it works when you're in the real world.
right. And so I'm being so many different facilities. I've seen so many different programs. When I was in school, we had to, depending on where you were at, we would say we wanted to comp on a certain organ, or something. Say I wanted to comp on a gallbladder. I would have to tell my preceptor, like, hey, I want to look at this person's gallbladder before I see the person, before anything.
Yeah,
And that
so you
was,
don't know
and
if it's going to be a good one or a bad. Yeah.
you have no idea what you're walking into. So sometimes you look at, like, if you look at people's ages, you can be like, okay, that's a
Yeah.
younger person. Maybe they'll be a better one to
Yeah.
see everything with. And so it was super stressful, saying I have to like have a competency and they have to like go over it, and they like have like, I don't know, like 20 different check marks. They have like, did I take good images? Did I have good rapport with my patients? Did I miss any anatomy? And like certain things were automatic fails. Like if you missed if you missed like gallbladder stones or something, like that was an automatic fail on that comp, and you can only fail comps so many times. And then like you got a bad, like, I don't know, grade, or like,
Yeah.
didn't make it through the program essentially, which is super stressful with different things, learning different things. I think that I haven't seen and obviously I haven't been in these programs, but the students that I've seen have not had as stressful clinical work, maybe same stressful didactic work, but clinically, when they're coming in with us is like comps, like they're just, just do this and do that, and then you just kind of sign off and say yes they did that, and then if they miss something, you just like go over it with them, and you still get the competency for that particular organ or that particular whatever. And so I feel like it's so, I mean, there was so many times, I can like, it was a long time ago, obviously I was in school, but there were so many times like I remember being so stressed out to like look for,
Yeah.
I did find like this, like, I don't know, something like the cervix. I'm like, and being like, man, I gotta find this, and I'm like nervous that I'm not going to be able to find this, and
Yeah.
and so I think now all the students that I've had, it's been much easier for them clinically. I think we're more just like apt to like, I will, if you miss it, if you don't see something, let me just sit down and go over it with you. Whereas like I would fail.
Yeah. So did you do that by yourself? Like you scanned by yourself, took
Yeah.
the
So,
images, and then someone checked it, or was someone in the room with you the whole time watching you scan?
and so I would have in the competency one, if I say like I'm going to comp on a patient, they would stay out of the room. And so they would allow me to not be, worried or scared somebody's over my shoulder, which I think is a really good thing, which it's, because I've had students where it's nerve wracking for me, especially going from place to place, to be in, like, I don't know, some places have had these students for a while.
Mm-hmm.
And so like they know how comfortable the students are with certain exams. Whereas like if I go somewhere, I'm like, I don't know how you scan at all. I don't know if what level you're at. And so it makes me really uncomfortable, like not being in the room. But I think where a facility that I was at, I like how they do it is they allow the students to go in the room. The student puts, whatever name they want on the machine. They do the whole exam, or they do certain organs they want to do. They come out, grab us, and then we go in, and then we literally start the whole exam fresh.
Mm-hmm.
And we do the whole thing ourselves. And then later we go sit down with that student and go over each image that they took. And then we can align it with the images that they took with the images that we took. And so it's something the radiologist never sees these pictures that these students are taking.
Yeah.
It's only us. So I really like that, they put whatever name they want, and then we just compare with the two different things. And so that way I don't have to be like, well, I go in after the student and I delete every image that they have because all the images suck, or something. The student's just like, well, I suck. Like, this is terrible.
Yeah.
And so I'm not pushing you down, but I'm able to go through each image that you took and explain like why you took it or why you shouldn't have taken it. And so I think moving forward, that's a way that I really like that. The hospital I worked at, the best thing that I've seen. I've seen both. I've seen where other places where you go in by yourself and the student takes images, and then you go afterwards and you check over their images and maybe take a couple more images, but leave what they have. I've seen other places where like, we were in the room with the student the whole time, and they would take an image and you'd say, okay, no, angle all the way through, or okay, no, angle up here, or like look at this area again, change your B mode on a kidney or something like that, which is just B mode. It's just the overall color, because we see so many shades of gray, but we see a lot of shades of color.
Yeah.
So you're more apt to see like a stone or something if you change the B mode, I think. And so I've seen both, but I think that's to every good thing, there's always a bad thing. And so I think the bad thing that goes along with that is the patients are going to be there longer, because
that's the first thing I thought about. Yeah. You double the exam time.
You're going to have and so like if you're packed and you're like, we don't have time, then maybe that doesn't particularly work for your facility. But I think if that's the best way, I think, for the student to learn and also not feel terrible when you delete everything they have, or when you have to, say they suck or something like, I think, but yeah, I think hopefully.
I mean, it's the same in radiology. If the attending deletes your whole report, you kind of feel like shit, and you're just like, well, I just wasted my whole time reporting that for you to delete it and dictate it yourself.
But at that point, I think the attendings also literally turn to you and say you suck, and then they
don't have to say anything. We know.
Yeah, for sure.
But so essentially, I mean, it's the same in medicine. You have a preceptor or whatever. Someone looks over your report. So now kind of explain how it's different now that you're out of school, and maybe, why some of the new, myself included, I would be a new grad. So why we're kind of nervous, at least from the ultrasound perspective, why they're kind of nervous about being on their own.
And I think this goes back to, before, as a student, I can take pictures, and if I'm not sure, you're gonna go over those pictures and delete those pictures. And it's kind of like, on a smaller scale, it's kind of like the radiologist, because the sonographer, like, they don't put the student's name on the exam. The sonographer that is overseeing you's name is on the exam. Maybe they put the student's name after it, but if there's a problem with that particular exam, the radiologist is going to call the sonographer and say, hey, Dennis, like, what is this? What are you doing? And then you have to explain yourself, or explain what the student did, that you allowed that image to stay on there, or why they took that, or whatever it is. And so I think that's where it becomes kind of a hassle if you're the attending or overseeing sonographer. But as a student, or as just a general new grad, it's stressful, because now I went from the sonographer that's overseeing me is taking all the credit, to now it's my name on there. Now the radiologist is calling me, and I have to explain what tissues I'm looking at, what this is, why I took this, or whatever it is. And so I think that's stressful, knowing that, like, I don't want to look like I don't know what I'm doing.
We can usually tell. I mean, people can tell when you don't know what you're doing. But
I mean, or like they ask you a question and you're like, I don't know, or so, like, I think that's the stressful thing, that you don't look like you know what you want to look like you know what you're doing, and you also want to make sure that you're doing the best results for the patients, because it's solely on you now. Kind of like it's with you guys. Like, I mean, you guys obviously take the credit for, or not take the credit, but take everything for the sonographer or whoever's images. I mean, it all rests on you in the end. And so I think that's probably the most stressful part, is knowing, and which will lead to kind of our other conversation. I don't know if you want to talk more.
Let's do. I want to hear some Wickham advice here for some. We got a brand new sonographer starting on Monday. What kind of?
Oh man,
let's give him a few tips.
I think looking back, if I was talking to my old self as a new grad, I think it would be, don't be afraid to reach out to other sonographers, even if they're like not happy about going over images with you, or you're a sonographer, you're registered, you should know what you're doing. If that's how they feel, then so be it. But I think you still need to be comfortable enough to say, okay, I want you to look over these images with me. Or maybe that's a radiologist that you end up going to and saying, hey, like, I'm new, sit down, and like, what are your expectations? What do you want me to do? The sonographers are like, don't want anything to do with me. Like, I think that it's important to try to lean on your coworkers if you have to, and don't be afraid to do so, because everybody's new at some point. And it all boils down to, like, we want the best results for the patients. And it's upsetting that another sonographer would like shun you or something. I've seen it happen.
It's going to happen. And
it's going to, and I guess that's something I would tell a new sonographer too, is like, be prepared, because there's other sonographers that will not want to help you, or will not care about you. Maybe find another one that does, or if you work in a small facility and that's the only one, then you go to the Rad, or you go to whoever you can to try to do what's best for your patients. I think that if you're nervous if there's something you don't know, I think take a picture. If it ends up being a pyramid and you think it's a cyst, take a picture of it. Take multiple pictures of it. Take a cine clip of it if you want to, and then go to the radiologist and say, hey, like, this is what I'm seeing. And if the radiologist says, well, no, this just looks like a pyramid to me. And so then you can go back and you didn't measure anything. Or if the Rad wants to measure something, they can, and say, like, hey, I saw this. You can measure it if you think it's something, but I don't want to put calipers on something, because then, I'm kind of
forced to say something.
I'm forcing your hand to say something, like,
it's
like normal renal pyramid was measured or something, but you're mentioning something, just adding more to a report that doesn't really need to be there. And so, and then, it goes to somebody else and they read that report and they're like, why? Okay, so this sonographer was not competent because now this radiologist has to make some sort of statement on something that they shouldn't have measured.
Yeah.
And so just going to give you a bad look, I guess. And so I think that's the biggest tip is don't be afraid to ask questions. If people get mad at you, like, so be it. Like, I don't worry about the people who get mad at you. Worry more about, like, things that you could possibly miss because you were too afraid to ask somebody, and then something, that's the most important thing is the patient. I don't want to miss anything. I'd rather ask you and look foolish than to be like, well, it was a sister. No, I'm just not going to take a picture of it. It doesn't exist.
Yeah.
And then it ends up being something that, you could have taken a picture of, but you just weren't sure. And so I think that's the biggest tip I can give. And also I think is something I've always told my students is again, treat your patients like a member of your family, or it's like somebody you care about, because it's somebody else's member of their family, whether it's their mom, their brother, their sister, whatever it is. And like, and I think that's why I've all the students that I try to, I never try to shun anybody. And for that reason, because my mom or my family member might be a patient of that sonographer's or that whatever one day. And I would rather teach you everything I know, because if you're taking, like, I want you to take good care of my mom or my family member. And so I don't, I know we all have bad days and things happen, but, like, I'd rather teach you everything I know and you take good care of people than say, like, no, don't talk to me. I'm about to retire in a year. Leave me alone. I don't want nothing to suit with you. So, but there are people out there that sadly are like that. Like, that's real. And so, those are, go ahead.
One thing I would add for that is, we talked about earlier about when I was in fellowship, they had to check the images with us before they let the patient go. So I would always add, for every, not just new grads, for every ultrasound tech, I think you guys should check the images with the radiologist before you send the patient home. Because if most radiologists won't add anything because they understand that our knowledge is limited in ultrasound, but there are some that are really good at ultrasound, and they'll want you to get they'll want to go get it themselves, or they'll want you to add get extra images, which is impossible to do if you send the patient home, because then you have to call them back. So it's a pain in the ass for the patient to come back, to get rescanned or, additional images. So one thing, just check with the radiologist. If he or she says, I don't want anything else, then let the patient go. It's just or you send them back upstairs, whatever. It's just so much easier that way. And then you mentioned measuring things. I think there are two types of radiologists. One love to measure fucking everything they see. And then I'm on the other end. I don't measure anything. I don't care if it's like a 10 centimeter mass. I'm not going to measure it. I would say don't measure something if you're not sure what it is. Talk, like you said, kind of talk to the radiologist first. If they want to measure it, let them measure it. But if I tend to be one that will just ignore things. So if I think it's a pyramid, I'm just going to ignore it. I'm not even going to put it in the report. But then with the advent, what if somebody sees it and they see your calipers that measure 2 centimeters? Like, well, why didn't you mention this?
Yeah.
Well, now it's my word against theirs. I just said, I know this is a normal structure. I didn't want to mention it. It's in there. And I only say this because one time someone told me, I think it was a chest X-ray or something. They didn't mention a granuloma, and the patient, because we've talked about my chart or whatever you want to call it,
Right.
and they saw their images and they're like, oh, what is this thing up in my left lobe or whatever? And they're like, oh, it's just a granuloma. It's nothing. He's like, well, you didn't mention it. He's like, it's not important to mention. But they're like, they said, if you missed this granuloma, which they didn't, they just didn't mention it. They're like, what else have you missed?
Right.
So a patient can be like, the sonographer measured something, you missed it, didn't mention it, whatever.
Yeah.
So then you kind of just lose credibility as a radiologist if you don't at least mention everything that you guys have. That's why I like where we did residency. I think did you guys push your little, oh God, whatever the sheet is that you write, you write down your findings.
Yeah. Like,
did that go through in the PACS or did you just give it to us?
I want to say it went to PACS. It's like an impression.
See, I don't like that because
I don't either.
I'm also forced to mention everything you've put on that piece of paper, even if I don't want to mention it. Say you mentioned gallbladder is slightly thick. I'm like, it's fine.
Right.
Well, you said it was 4 millimeters, which is technically thick. So now if I just blow it off, they're like, So I like just a piece of paper you can hand me, or you just tell me verbally what you saw, and I remember it.
Right.
I don't like the going into the PACS. It's kind of too official, right? Because like you said earlier, I take responsibility for all this. So I mention what I want to mention. And most of the time I just mention what you guys say, unless I feel strongly about it. But I think it's just a tricky situation when it's pushed. It's actually in the PACS system for everybody to see.
And I'll tell you what, and kind of jumping off of that, I really dislike I think we call it our impression sheets. I don't like putting those into the PACS because then those become a part of the patient's record.
Medical record, yeah.
And so that patient goes in there and they say the sonographer said, whatever abnormality it is, but the radiologist didn't mention that. And and what's crazy to me is I have a lot of radiologists that I've known that rely heavily on our impression sheet, which I think it's a tool for me to say, hey, like this is what I saw, confer or not. But I just don't like it being associated with the patient's record because my impression of I take images and then you make dictations. Yeah. My impression of whatever it is, my impression is those pictures. Those pictures that I take, you look over those pictures and then you make the dictation. And if you have any questions, then call me and I'll say, hey, like I think this, and this. I don't know, like other places I know I've worked at that we put like in the notes section of something, so it wasn't a part of the patient's record, so you could see what I'm saying, but it's not a part of, I'm not making a dictation for that particular patient. So it can be, I think, and I don't know the legality, I'm not a lawyer, but that can be like confusing and like scary because now I'm a part of your record. I say you have gallstones when it was just a gallbladder polyp. And so that stuff that leaves me incredibly uneasy. And then and to top it off, and like a quick aside story, I would put down echogenic mobile foci seen in gallbladder, or echogenic shadowing, or echogenic twinkle artifact seen in kidneys. And I have radiologists that call me and say, is it a stone on a kidney? And I'm like, and they're like, I don't want you to describe what you say. I want you to say kidney stone and then send it over. And I'm saying like, and I had a big conversation with management saying like, that's technically out of my scope of practice to diagnose and put it on a patient's record and then scan it in. Like that's out of my scope of practice, but it's so normal that they're like, and I'm like, if I describe something like that to you, like, it's a stone, like you looked at the images.
Yeah. I mean, if you give me that description, I know you're trying to say that it's a stone.
Yeah. Like it fits everything. You looked at, I give you the description, you look at the images and you call me to say, is you're saying stone? Just say stone. And I'm like, no, like that's not what we're supposed to do. Like,
I mean, that's probably more of our job. I wouldn't put echogenic twinkling. I would just say it's a stone in my report. I would just say it's a stone. I don't give a shit about all the descriptors, but I'm fine if that's what you say, as long as you're giving me a strong enough hint to say that if
Right.
I say, oh, I think this is a stone, what did Dennis say? He
Hmm.
said, oh, he said this. He's describing a stone. We
Hmm.
agree.
Yeah.
So then I just call it a stone in the report.
And that's crazy because these, like, I did it multiple times. I had multiple conversations, and it
Yeah.
came down to, like, Dennis, you need to stop saying this, and you need to just say what it is. And I'm like, that's your job.
Yeah.
Your job is to
Yeah.
say what it is. My job is to take pictures, describe what I see, and then you say whatever the heck you think that is. And
Yeah.
so, yeah, I think that's kind of a scary, like, thing that is
Yeah.
coming, and
And
it's
we've talked about it before, and I think it's a good segue into, the next topic we wanted to talk about, but kind of what happens when you do, because it's going to happen, not when, not if, it will happen. You're going to miss things
right.
or to misdescribe them, whatever. Something is going to happen. So I think this is probably a good
Hmm.
bridge for you to kind of talk about, at least from your perspective, when you miss something.
Right.
Maybe you didn't know you missed it at the time. They get another exam and they confirm the finding or whatever.
Right.
So I think it's a good point. I can talk about it at, my perspective too, but
Yeah.
I'm interested to hear how it goes from the, the tech side of
Yeah.
things.
I think, from the sonography side, I think it's like anytime that you miss something or you make a mistake, I think it bothers you if you care, and
Mm-hmm.
everybody should care in this field. I mean, people's health is important, and so we've all missed things from, I've taken images before, and then a CT caught something else, or I've taken
Mm-hmm.
images and another sonographer came in when I was new and they saw something that, I was like, oh, I literally just looked in that area and I didn't see that. And so we all, and then I think the hardest thing is sometimes when you feel like you miss something and you don't know what it is, something doesn't. I've had a conversation with a radiologist about this. I was like, I feel like something's off. I don't know what it is. I don't know where it is. But I feel like I'm not getting the image to, like,
Yeah.
say what's wrong, and then turns out down the line and end up being, something. And so I
Yeah.
think that is the hardest thing. I mean, from certain, I mean, because especially with sonography, I think it's a skill, and it's obviously user dependent, and so it's based on skill level, and it's based on the amount of times that you do that particular
Mm-hmm.
thing. If you haven't done second, third trimester OB, LVOT, RVOT with the I'm talking about the heart in a long time or ever, then your skill isn't going to be as good as somebody else. I mean, just like, riding a bike or whatever it is. Like, if you ride all the time and you jump, and you're going to be better at it than the person who just jumps on it. And so, with those skill levels differentiating so much from experience, I think that, things can be missed, and
Yeah.
it can be stressful, and sometimes you go home and you feel like it sucks. You're like,
Yeah.
why did you get that and I couldn't see it? And I think that you want to be hard on yourself because you want to care, but you don't want to bog yourself down,
Yeah.
to the point that it's terrible.
That's the
And
hard
so,
part. Yeah.
yeah, and take those things. And I think that, the best thing you can is if you do something, and then I've seen things done where they did one exam and then they called the patient back. The patient comes back in having the same problem 2 weeks later. They do the same exam and they see something,
Yeah.
and they're like, and then you have to be like, okay, well, who did this one? And then who did this one? And what's helpful sometimes is that, we all look at the exams. I mean, I shouldn't say we all. I try to look at every exam that would be pertinent to the exam I'm
Mm-hmm.
about to do, whether that's a CT, an MRI, whatever it is. I'll go through the exam, read the report, look at the images. And so when I go and see that patient, I know as much as I can about what I'm about to look at. And so I think if somebody comes out of the room and they know, hey, John did this exam before me and didn't see this, John's here today. What I'm going to do, if I'm a good sonographer, and this is my opinion, I'm going to go grab John if I can and say, hey, come with me into the room. I want to show you something, and
Yeah.
allow them another chance to take a look at that area and see, hey, like this is what I'm seeing. I know you didn't see this last time. Either it wasn't there or you missed it or whatever it is, but like
Hmm.
this becomes a teaching opportunity. I'm not doing that because I want to be like, hey, I found this and you didn't. Like, I'm
Yeah.
doing this because I'm like, I want to show you for next time, maybe you'll see it differently. You'll see it this way. And that's, I think that's a great thing if you're able to like, if you miss something and somebody's able to bring you in and show you in real time, like, this is what you missed. This is how you find it. And then that's where growth happens. And then maybe
Yeah.
the next time you see that the next time. And so it's like Gage said, it's not if, but when,
Oh
uh,
yeah.
because we're all human. We all have different experiences and we all have different
I mean,
training.
it's hard to explain to patients, like non-medical people,
Yeah.
just how, especially in radiology, how much we do. But we say when, not if. I can give you my example for
Mm-hmm.
fellowship.
Mm-hmm.
We were able to sign our own X-rays for like 9 out of the 12 months.
Mm-hmm.
And then when you get a new job, your job wants to see your log, like what you've done over the last year. So I had to give my job the numbers that I read. And me, so this is just one radiologist in one subspecialty at one hospital, including a little bit of moonlighting. I was over 10,000 x-rays by myself. So the odds that I'm going to miss something on one of those x-rays is extremely high. You take 10,000 steps, you're going to trip at
Right.
least one of those steps. And
Sure.
we all walk every day. So
Yeah.
that's why we say it's not if, it's when, because I read over probably 15,000 exams,
Mm-hmm.
last year. So
Yeah.
that's just me at one hospital.
Right.
There's thousands of us across the country reading hundreds of thousands of studies. So
Right.
things are going to get missed. It's going to happen. So if you're like listening and you're thinking like, oh, that's never going to be me, one, you're already behind. Like if you don't think you're ever going to miss anything, you already have the wrong attitude.
Right.
So you're going to miss. You just have to learn how to handle
Yeah.
when it inevitably does happen.
Right. And I like the way you put that, 10,000 steps, you trip, 10,000, whatever it is, like there's going to be some sort of an error, but
Hmm.
the listeners at the same time, I don't want you to be
Yeah,
nervous
yeah,
or worried
yeah,
that like, oh, I'm going to be that miss. There's other,
yeah.
if just, we're talking about this because if, something's not seen on your ultrasound, maybe they order that CT or they order that X-ray or there's other things,
Yeah.
other avenues that we might be able to, that maybe we didn't see at that time, but we catch it some other way.
Hmm.
And then certain things are seen better other ways too. They say,
Yeah.
you missed my gallbladder stones on my CAT scan, but you saw it on my ultrasound. Ultrasound's better for that kind of a thing.
Hmm.
And so maybe it's not that that person maybe missed it. It's that this modality was better for that. And so,
I think that's another thing that's hard to explain to patients is if they come in for a CT and they're like, oh, I just had an ultrasound of whatever.
mhm,
It's hard to explain to them that CT is better for this indication that we're looking for, or MRI is better. They're like, why do I have to get my kidney scanned again? And it's so, yeah, like it's, even if you miss something on one modality, other modalities are better for
yeah,
certain things and more likely to be caught. And,
right,
I mean, like a chest x-ray is not perfect. A chest CT is going to catch more than a chest x-ray. That
right,
doesn't mean the chest x-ray is useless.
right.
So I think that's one thing to take away. It's kind of a little tangent, but
Yeah,
you know,
it's not even in those instances, it's not even a miss. It's just,
mm-mm.
it's not able to be seen as well
Yeah,
as
I've seen like
whatever.
5, 6 centimeter masses that you don't see. You just don't see it on the chest X-ray, and I
Hmm.
mean it's glaring on the CT. It's just so
Hmm.
obvious, but it's kind of just reiterates the point that certain modalities just aren't good for certain things.
Right. And I had a case once. I was talking to a radiologist, and I think it was just like a kidney cyst that I was following up, and I was like, I don't see this kidney cyst. This kidney cyst was located there on the last CT, it was like two CTs ago it was there,
Hmm.
and then on the last CT I don't see it there, and then on this ultrasound I don't see it there. And he was like, he's going through and he's like, okay, it's perfectly like clear as day on that two CTs ago, and then the last CT, he's like, it looks like it was called again on the last CT. He's like, but it doesn't, I can't see it there on the last CT, and now we don't see it on the ultrasound. And so like
Yeah,
stuff like that happens too. I think that like
yeah,
I mean, I don't, not that things like go away or get better, but like, I guess sometimes things just change.
yeah.
Uh, and I think that's part of it as well.
I mean,
It's
ultrasound is, I mean, I think ultrasound, the techs specifically, I think radiologists are a little bit better at it in terms of we know that ultrasound is like more of a screening modality. So if I see something, you see something on on ultrasound, and you're like, I don't know what it is. I don't know what I don't know what it is either. Then you just get an MR or a CT. So I think if you keep your limit, if you know your limitations, you know what you don't know that you're going to miss certain things. You know what I mean? Like it's as long as you're not a pompous asshole about things, I think
no,
you'll be all right. But
right. And I've ran across those too. I mean, you know what you
yeah,
don't know. That is so true. Know what you don't know, and I think that's a great thing for the new graduates. Try to know what you're good at starting out, and know what you need to continue to work
yeah,
on starting out. And that's just not new graduates. That's everybody. Know what
everybody. Yeah.
know what you're good at, and know where you need to continue
I
that
mean,
work.
even here, we have attendings. I mean, they've been doing this for 30, 40, 50 years. They don't know everything. So they still ask other people, like, what do you think this is?
Right.
So, I mean, it doesn't, sure, they know more than the average person, but they still things they see and they're like, I don't know what this is.
Yeah.
So, surgeons do it, we do it, everyone does it. So, no one's immune to it.
And learning doesn't stop after school for sure. And
Yeah.
so
Yeah.
I think that's super important.
And I've had attendings tell me the first 5 years, from a radiologist perspective, the first 5 years as an attending is actually when you're going to learn the most.
Yeah.
Because now my name is the only one. Right. So you've mentioned before how you've seen radiologists they live on what we call Radiopedia, right? Which is it's just a mass. It's a website that we get all our information from.
Right.
And that's why we learn so much, is because you're scared because it's the first time your name has ever been by itself at the bottom of a report. And two, you're just like, if you're in the hospital by yourself, you can't ask anybody. So if someone's there, you ask them, obviously, but you just spend so much time checking, double checking, triple checking. You're like, man, this is a cyst. Sure looks like a cyst, but what else could it be?
Right.
You pull up Radiopedia and you find all the other things it could be, and you're like, no, I think it's a cyst. But so you still do a lot of learning,
You know what's interesting? They told you that. It's so funny because my preceptor in schools, and when I was in school, would say the same thing. The real learning is going to happen within the first 5 years. And what's interesting is they also said, she said, he said, eventually you're going to get to a point within that like first year, you're going to start doing exams really fast.
Yeah.
And then after 5 years, you know more. And so you actually slow down.
Yeah.
And so you're going really quick in the beginning. You're like, oh, and just kind of flying by. And then the more you learn, you start to slow down just a little bit more. And I don't know if that's part of age or if that's just like I know more. And so I just want to look at these things a little bit slower. But the crazy, I've noticed that when I started out, it was, I can get exams done. I'm flying through exams. And now it's like, okay, I know this, this, and this. And so now I take more time and I do things a little bit differently than when I was just fresh. When I was fresh, I was also, trying to bend other people's brains and use them. But now that's so cool that they also told you basically the same thing. 5 years. Yeah.
I guess we'll find out. I have 5 years. So.
We'll find out. Well, we'll still do this podcast in 5 years. We'll tell you guys.
I mean, you already pointed out, I don't want people to think that we just miss everything.
No.
There's I think it was the ACR that posted it. Radiologists have like a 2 to 5% major error rate, meaning like if we miss something that's going to kill you or seriously harm you, it's not a very high rate. So
yeah, and that's, I think, and that's the biggest thing, and that's a great point, is the major stuff isn't stuff that you're usually going to miss. Maybe you look over something that's not a big deal, whatever it is. It's
higher. Yeah.
And
it's the granuloma, like whatever. Yeah.
It's just like walking. Like you're walking and sometimes you trip. Like you miss a step and you trip and you stumble and you catch yourself, whatever. But then sometimes you're walking and you fall.
Yeah.
And like that doesn't happen.
That rarely happens, but
it rarely happens.
Yeah.
But sometimes it happens. I like that. I like your little analogy there.
Yeah. I mean, there are two major types of errors. I don't know if anyone's ever told you this, that radiologists make. One is you don't see it, so you just miss the finding.
Mm-hmm.
Two is you see it, but you call it the wrong thing. When you're young, training, you just miss it, right? You don't know what you're looking for, so you just miss it. The second one is more common as you get older. You see it, but you think you call it A, but it turns out to be B. So I want just to say that missing things is very rare. Like just missing them blindly is rare. Usually we see it, but we call it the wrong thing. We call it a complicated cyst in the kidney, and it turns out it's like a early renal cell type of thing. We saw the finding, we just thought it was this. Turns out it was something else.
Right.
Yeah.
And I think that's common in sonography as well. I think that we take pictures of stuff and we see the same kind of things all the time. Yeah. So we'll take a picture of something and you're like, oh, it looks cystic, and it ends up being solid.
Yeah.
And you're like, okay, like, well, I took pictures of it, so that's I did my job, I guess.
Yeah.
And I didn't miss it, but we thought it was the wrong thing. And so, yeah, I think those are also misses, but no, and I think that's the whole point of this is, we're saying like, we're not perfect, but we're pretty close to doing,
we do our best. Yeah.
Yeah. To doing it.
I think people want us to be perfect, but nobody's perfect.
Yeah. Yeah.
Which includes includes doctors, techs, nurses, everyone. We're not.
We're all trying to do our best. And I think that's what, in this profession, I think that the majority of people that I've met are trying to do what's best for the patient, care for people, because you're dealing with people at their worst, at their angriest.
Yeah.
And you're still trying to, especially this is kind of an off topic, but especially nurses and like the ERs and things like that, where people are coming and fighting, and it's hard to continue to give great care when somebody like is trying to hurt you or is trying to be violent or whatever it is. And so as medical folks, you really deal with a lot of like people at the worst.
Yeah.
And you try to have, there's a great video about empathy with the Cleveland Clinic did 10 years ago or whatever it is. And just trying to empathize with somebody's situation that you might not understand, but you try to put yourself in their shoes. Okay. So looks like we've talked about the training. We've talked about the near misses. We've talked about being new. Do you want to go into your favorite?
Let's do this segment. Okay. Yeah. Okay. So we got today's question. I'm going to read it word for word. I don't know where if I thought of this on my own or if I saw it somewhere, but today's question is, give me, I guess, the one or two things that you've learned either in general or about yourself since starting the podcast.
I think one thing I've learned about myself is that I enjoy making the podcasts. It's hard to find time to make them week after week, just find this hour. Somehow we always end up doing like an hour-long segment.
Yeah.
And I know our schedules are off kilter, so that kind of makes it more difficult. But I think that I don't enjoy making all of the social medias as much. And you can obviously tell I'm not.
Yeah, I'm the exact opposite. Yeah.
Yeah, I want to be better at that, but I'm just like, I guess I don't really want to be. I guess you just feel like it's kind of like anything else. Like, do you want to be better at it, or do you really not want to be? Because if you cared, like, you would do more about it. And so I feel like that's something that I want to be better at. I'm trying to get better at, but I need to be more on the social medias. I need to post more of the funny TikToks. I need to try to more of the YouTube shorts out there.
Yeah, check out our shorts. I'm killing it lately.
Yeah, he's still, oh my God.
If you like wrestling,
if you have any understanding of any wrestling, his stuff is on point. If you see the wrestling stuff, Gage has been killing it.
Yeah,
it's so funny, and so that's the kind of stuff that I'm like, I see those, and I'm like, man, that's hilarious, that's great, and I'm like, I need to do that. And so those are things about myself that it's one of those things like, it's like, how bad do you really want it? And I want this to grow and I want this to be successful. And maybe that's something I'm learning about myself, that I need to be able to dedicate a little bit more time and do those things. Maybe I don't love those, maybe like, there's always something you do that you're like, I don't really enjoy this part, but I like this other stuff. And so, which I think is really cool with us, is that I don't love that kind of stuff, but you're freaking awesome at it.
I enjoy it.
Yeah, so that's really cool. And what's great now is you're going to be out of school finally, and so
Yeah.
you're not going to have to do all that kind of stuff too. So,
Yeah.
but yeah, I think those are my answers. I'll let you go ahead.
Yeah. I mean, I think mine's along the same lines in terms of I didn't realize how hard this would be. Obviously, you just mentioned, I think I want the social media stuff to grow more than the podcast. I don't, I think we're doing the opposite. I use the social media to feed the podcast,
Mm-hmm.
whereas you're probably more using the podcast to feed the social media.
Yep.
But I didn't realize how difficult. It's not like physically demanding, obviously. It's not even that mentally demanding
Mm-hmm.
compared to what our day jobs are. But I mean, it's just not easy to like, when you post the first podcast, and I don't know how many views it has now. It's not very many, but just to like know that you're posting this stuff, nobody's watching it,
Mm-hmm.
so you hear about all these people that Gary Vee and so forth, like stream to nobody. I watched a whole bunch of Twitch streamers that in the beginning, like I just streamed to nobody for like a year and a half. And then, slowly it took off.
Yeah.
I mean, I should know a little bit about, playing the long game because I just finished like 14 years of this to be a doctor, but it gets frustrating.
Yeah. Yeah. It's tough.
So I underestimated, I guess, exactly how difficult it would be. And even like what I do post on YouTube and stuff is not us, right?
Mm-hmm.
It's Ric Flair with just
Yeah.
medical humor on it.
Right.
So they don't even like us per se. They just like the fact that what I said was funny.
Yeah.
So I think that was one thing that was hard to,
Mm-hmm.
but I do enjoy the social media. I don't post on my normal social media hardly at all,
Right.
but I try to post on ours
Yeah.
more frequently. So I
Yeah.
definitely enjoyed that part of it more than I thought I would.
I think that's kind of a cool thing that I think the social media allows you to kind of show when you're posting on your own, you're showing, I don't know, you're showing your friends and your family like just stuff about you. Where this is like,
Mm-hmm.
not that you're like hiding behind a mask or something, but like,
Yeah.
this is like our maybe one day business that we have or whatever it is. But yeah, it's so tough to that long game because I had a Gage knows I've had a podcast before. I did 13 episodes, and so this is going to be episode number 9.
Yeah, so almost there.
And so I almost caught my last one, and I'm like, we've been off now for what, 2 weeks or so. We haven't
recorded.
Yeah, we haven't recorded, and so I'm like, I want to keep this going, but it's like you said, like Gary Vee's like, I did it for a year and a half and I didn't have any listeners, I didn't have any watchers, I didn't have any viewers, like, and I was posting on this and posting on this and like, and then all of a sudden one day, like somebody saw it and it like took off.
Yeah.
And so I'm hoping that maybe if we keep this going, maybe one day somebody's going to see it and it's going to add some sort of value to our lives and values to other people's lives. And
I think one thing that's crazy, I'm going to catch flack for this probably, but
okay,
is I think we get more support, at least on my side of things. I get more support from the random people on the social media. I think you have more, like most of our listeners probably come from your side, the people that you've told about the podcast. But if you pay attention to when we post on Instagram, what are they called? The reels, they don't do very well. Right? Mm-hmm. And that's mainly we're posting, the people that follow us see that. The people that follow us are our friends, family, whatever. Mm-hmm. But then I post something on YouTube and then you get 1,000 views or whatever. They don't know us.
Yeah.
So I thought, to me, it's just been crazy that at least I've gotten more support from people they don't know who I am. I don't know who they are, right, as opposed to people that are closest to us. Whereas I think you probably had a little more support from people that were, that you're closer to.
Right. And I think that's that's like a good thing though, at the same time, because maybe the people I'm closest to aren't really into radiology, or they're not really into sports or whatever it is. But like the people who are into it, these random people, they're listening to stuff they enjoy.
Yeah.
And hopefully we're enjoyable eventually.
Yeah. That's the thing that people always, this isn't really something we've learned, I guess. Mm-hmm. But it's more of advice that I've seen. We go back to Gary Vee, but I've seen him give it specifically, is like, you have to make content that you enjoy. You make content for yourself and just hope that other people enjoy it as well. Whereas if you can tell when people make content that they enjoy themselves, mm-hmm, versus content they think other people will enjoy. Right. So if you do the second one, you're not going to be very happy for very long, because you're trying to predict trends and all this other stuff that you think people are going to enjoy. And Whereas if you do what we do and kind of just talk about whatever we want that's enjoyable to us,
Mm-hmm.
our following may be smaller, but it'll be organic and the people will enjoy
Right. Right.
what
Yep.
we're talking about.
I agree. Yep. I think that's the most important thing. I literally just had a conversation with somebody the other day, and I was telling him that I was like, I think I'm doing this just because I enjoy it. It
Yeah.
lets me. I said it lets me hang out with one of my best friends.
Yeah.
I don't get to talk to a whole lot, and so like that's just spending this hour hanging out with you. Like that's fun for me, and getting to pick your brain about where you're at with your fellowship or whatever you're going on in your life, or you're moving, or you're whatever's going on with your life. It's just a cool like opportunity.
And I think it's nice because neither one of us rely. This doesn't have to be successful, right? If we make money, we make money. If we don't, we don't. We both have jobs that are going to pay us well above what even an average person would make. So we don't rely on this for anything, right? But because I always see people you see like I don't know what you want to call them, influencers, I guess, but they give like, to me, it's dog shit advice of like never have a backup plan, like go all out, yada yada. I think that's dog shit advice. You should always have a backup plan. Mm-hmm. For us, this is our backup plan. Our day jobs would make us more successful than this is likely going to make us in the long run.
Right.
But so I think it's nice that we don't have to, the fact that we haven't recorded in 2 weeks, we don't rely on this for anything. So I think it makes it a little less stressful because we're not relying on views on YouTube for our monthly check to pay our bills and rent and stuff like that. So,
which I think is also interesting because I was reading something the other day that said sometimes, and this was like a business thing, but they're like, sometimes you have to let a business go.
Yeah.
Continue to work on the next thing that might be more important. And so I think this is not like something that we have to let go, but we can just allow this to, like you said, grow organically, grow slowly. If it turns out into being something that's really cool, which would be great if we got like Dr. Pepper.
Yeah. We're not saying we don't want those things, but I mean, I think you have to be realistic.
Yeah.
Gary Vee was at a time that's different than us where he was first starting. YouTube was barely a thing. Mm-hmm. Nobody was doing what he wanted to do. Right. Now we have the opposite problem. We're not blind to the fact that the podcast market is vastly oversaturated. YouTube people, it's oversaturated. Like all this is, there's a ton of people that do what we do.
Right. But I think where we can really where we're going to continue to separate ourselves is this niche of the hospital area that we work in, and hopefully we continue to answer certain questions that maybe people have or concerns, and we can go over real life things working in the hospital, and so people can have a better understanding. And so we're the crazy YouTubers that are just doing all these crazy stuff, and maybe they're making tons of Mr. Beast, whatever, making all these money doing all these things, where we're focused on just creating this niche. Hopefully we continue this for the long game. I want to at least get past 13 episodes.
That'd be easy. Yeah,
that's my goal. On episode like 14, maybe I'll wear like a party hat or something. I don't know.
Yeah.
But this is hopefully that answers all. That was a good question. I really like that question at this point, because sometimes sometimes I get to the point and I'm like, are we going to continue this thing? And I'm like, no, I want to continue this thing. So
I mean, we'd do what, 3 months, 2 months?
Yeah, I think 3 months.
Yeah.
Which is, we've
hopefully
got
with this episode we hit 100 downloads. I think we're close.
Yeah.
And
then hopefully next episode, dude, we've got a surprise. Possibly we might be wearing some apparel. We'll see. We'll see how that goes. And then if so, we'll put a link if anybody wants any stuff. We'll see. We'll see we'll see. You guys are
we'll see how it goes.
Yeah.
I mean, it's the fact that we don't have to rely on this. You can just let it go.
Yep.
I worry about the social media side. You worry more about the podcast side. So I think it works out well.
Yep.
But with that being said, I think
that's it. Yeah.
This might be our shortest episode. We did good today.
I think we did a great job.
Yeah. But we are on Instagram. We're on TikTok. We're on YouTube. YouTube's my favorite. So if you're going to pick one, go to YouTube. It's rad_talk_DG. My I guess you call them memes. My wrestling medical memes have been on point lately.
Killing it.
So go give those a look.
If you want to laugh.
And then, yeah, we're on Podbean, Spotify, and Apple. And I think you just search Rad Talk.
Yep, we'll be the first one.
Yeah, that's right. First one.
Yep.
And then the last one I don't remember. The email.
Rad Talk with DG
there you go.
gmail.com. Yep, shoot us an email if you want to.
Questions, concerns, comments.
Or if you want to sponsor us, shoot us an email.
Yeah, Dr. Pepper, I DM'd him, so we'll see.
Dr. Pepper, we'll see how it goes. But, yep, okay, man. Well, until next time, we'll see you guys hopefully next week.